Idiopathic toe walking describes the process of walking on the toes or the metatarsophalangeal joints, whereby a definitive cause or reason is lacking. Toe walking is a bilateral gait abnormality that occurs in children who continue this habit beyond their toddler years. And though it is a natural process exhibited in some children when they are learning how to walk, many will find that they outgrow the pattern on their own. A study published in Sweden consisting of over 1,400 children concluded that 5% of children had exhibited signs of toe walking at some point before the age of 5.5 years. Practice is a model used in healthcare to improve patient outcomes by integrating three fundamentals consisting of clinical expertise, patient values, and best research evidence. The 5-step process involves formulating a well-built clinical question, finding the best available evidence, critically appraising the evidence, implementing the evidence, and evaluating the outcome. Using the PICO method, we were able to focus our efforts specifically on what was important and identify the most relevant studies. In this case, the population and problem was idiopathic toe walking in children. The intervention focused on surgical therapy such as Achilles lengthening, and the comparison was to non-surgical interventions such as physical therapy, stretching, and serial casting. Our key follow-up outcome was improved ankle dorsiflexion both short and long term. Refining the question gave us the ability to identify the key outcome we felt was most relevant to the pathology and was included in most studies as a quantitative measure.
To acquire the relevant information, we used numerous databases which we accessed through the La Trobe University Library under Databases. We then selected the by-subject category and chose podiatry. The databases we decided to choose were Medline and TRIP. Keeping the search in context with our PICO question, we began by searching treatment for idiopathic toe walking in pediatrics and idiopathic toe walking on the Medline database. We selected the map to term subject heading and began to scope to see whether we wanted to use the explode strategy for more information. We initially just decided to search treatment for idiopathic toe walking in pediatrics as a key term and was given 9 results. Similarly, we searched idiopathic toe walking as a keyword and received 54 results. Following these searches, we researched the same terms and set combined selections to and exploded the terms child and ankle joint. These specific terms displayed 12 results for idiopathic toe walking and 5 results for treatment of idiopathic toe walking. From these results, the relevant systematic reviews and RCTs were selected. Whilst we had a number of results from Medline, TRIP was another database we selected. We searched the terms idiopathic toe walking into TRIP, which returned 97 results. Of these 97, only a few were relevant, in which we had the same ones from Medline.
The evidence from the Kujic et al. Review suggests that both surgical and non-surgical interventions can improve passive ankle dorsiflexion in idiopathic toe walking patients. However, effects are only sustained longer than 12 months in the surgical groups. The study was also able to conclude that botulinum toxin A did not improve the results of serial casting. The review included relevant studies, but not all was high quality. Limitations included no pooled data due to the low amount of high-quality methodological studies found. None of the studies controlled for co-intervention, which makes it difficult to attribute the observed effect as a result of a single intervention. Articles were limited to Dutch, English, and French and German languages. In the systematic review conducted by Van Bemmel et al., 10 trials with 298 patients were included as they were investigating increased dorsiflexion after surgery or serial casting. The median follow-up was 3 years after casting and 3.3 years after surgery. The average increase in dorsiflexion for the serial casting group was 3.1 degrees and 14.2 in the surgical group. None of the studies included, however, were randomized controlled trials. The study was also limited to articles written in Dutch, English, French, and German languages. Only finding retrospective studies was a limitation of this systematic review. All the studies investigated the effect of casting and surgical interventions, but did not include other non-surgical interventions such as physical therapy and botulinum toxins. The article also suggests dorsiflexion values may be skewed because values were lower in the pre-treatment of the surgical group than the non-surgical group, meaning the subjects most likely had a milder deformity in the non-surgical studies.
The management of children with idiopathic toe walking has been much debated, with the history of the pathology not being fully understood. When assessing literature, increased dorsiflexion seemed to be the primary goal, with many conservative treatments put in place, which included physical therapy, serial casting, foot orthoses, and botulinum toxin A. These treatments were generally used in combination rather than being a sole treatment. Children who tend to walk on their toes are constantly plantar flexing the foot, causing gastrocnemius and soleus muscle contracture over time. This contracture leads to a less than 10 degrees of normal dorsiflexion of the foot, which affects the child's gait and puts them at risk of other musculoskeletal pathologies as well. The literature now established that 50 to 70% of children with idiopathic toe walking have limited ankle dorsiflexion, which is attributing to the pathology. The systematic review we acquired by Kurge, Costas, Verks, and Gertz assessed 19 studies on the most effective treatments for idiopathic toe walking. They report that 5 studies analyzed showed increased ankle dorsiflexion immediately after serial cast had been taken off. However, only 3 of these 5 studies actually statistically quantified the improvement of the ankle dorsiflexion. One of the 3 studies had a 6-week follow-up, and the other one had a 6-week, 3-month, and a 6-month follow-up post-treatment of the serial casting. Both studies showed an increase in range of ankle dorsiflexion at the follow-up appointments. Another systematic review by Bemmel, Graf, Beckerum, and Vergerson assessed 10 trials with more than 430 patients involved. Patients that were reviewed in the trials had been through surgery or conservative treatment such as orthotics and serial casting for a minimum of 2 weeks. 8 of the 10 studies provided details of the patient's ankle dorsiflexion before and after treatment. A sum of 72 patients which had been casted reported an increase of ankle dorsiflexion with a mean of 3.1 degrees after a follow-up of an average 3.3 years. The authors reported that although there was some satisfaction with the results, it should be taken with care clinically. In addition to this, Fox, Deacon, Pettigrew, and Payton conducted a study where patients over the age of 2 had been primarily diagnosed with idiopathic toe walking were invited to participate in a prospective study in which their conditions were reviewed. 44 patients were included in the study, in which all of them were treated with serial casting 2 weeks with 2 weeks intervals, and were instructed to perform gastroc stretches after the cast had been removed. The review indicated that 29 of the 44 patients had either stopped toe walking completely or improved enough for the parents to be satisfied. Following the casting, 29 patients who'd improved showed a better ankle dorsiflexion compared to the patients who showed no improvement. If the conservative measures do not attain adequate ankle dorsiflexion, the surgical option should strongly be considered. Surgery for idiopathic toe walking consists of surgically lengthening the Achilles tendon. The lengthening will in turn increase ankle dorsiflexion and the ankle range of motion during gait. The systematic review appraised by Bemmel, Graf, Beckerum, and Vergerson also assessed articles which use surgery as a mean of treatment for idiopathic toe walking. The 8 out of 10 studies that were assessed used a surgical procedure with either a combination of conservative or directly to surgery. The average pre-operation ankle dorsiflexion amongst the 185 patients was 6.6 degrees. The average post-operation measurement of ankle dorsiflexion was 14.2 degrees, which shows a considerable amount of increased ankle dorsiflexion and ankle range of motion during gait. Kujic, Costas, Verks, and Gertz also included studies in which surgery was considered. 4 studies they included looked at surgically lengthening the Achilles tendon to allow for more ankle dorsiflexion. With an average of 3-year follow-up in these studies, they reported a long-term success with ankle range of motion still within normal limits. Another study by Hemo, Makdessi, Pierce, Aoni, and Sussman reviewed 15 patients who were treated conservatively with no positive results. The average age of the patients were 9, with a mean follow-up of 2.9 years. Pre-operative measurements of the ankle joints of ankle dorsiflexion were minus 7.5. Post-operative had a mean value of 11.6 with these patients. When considering limitations, some of the limitations Bemmel, Graf, Beckerum, and Vergerson's review were that the studies were only retrospective studies in which some of them differed in terms of baseline characteristics, making it hard to pull data and compare some results. In addition to this, a child's life may also be negatively impacted through being in a cast and unable to do daily activities. With the Kirk, Costa, Verks, and Gertz review, even though the studies show immediate improvement, serial casting seems to be a short-term solution. The studies show a decrease of 6 degrees in ankle dorsiflexion compared to the values in which measured after primary treatment at an average of 2 years post-op. In addition to this, Hirsch and Wagner, 2004, conducted a study in which 16 former patients with idiopathic toe walking were asked for a follow-up appointment after being treated conservatively using casting and orthotics and physical therapy. After a 7 to 21 year follow-up, they found no systematic improvement in ankle dorsiflexion range. Another limitation the authors suggest is that the exact relationship between toe walking and decreased range of motion of the ankle joint is not clearly established, and it is not clear which pathology arises first. In terms of the limitations of surgery, the values from Bemmel, Graf, Beckram, and Ferguson seem huge compared to the conservative treatment. This is because the pre-treatment measurements were lower when compared to the conservative treatment. This makes it likely that deformities in the conservative group were milder, meaning better results are expected from the surgical group. In addition to this, the ankle dorsiflexion may have increased, but only 4 studies demonstrated satisfaction in terms of treating the idiopathic toe walking. With the Kirk, Costas, Verks, and Gertz, even though operation may be indicated in increasing ankle dorsiflexion, it is wise to consider the cost and mental effects it may have on the kid. A child undergoing surgery may impact the family considerably, as surgery is expensive. In addition to this, the recovery time of 6 to 8 weeks must be considered in how it may impact the child mentally. Being in a cast while friends are playing sports may sadden the child and negatively impact their quality of life. Although conservative management is fairly non-invasive and should be considered, it can often be hit and miss. A study conducted by Eastwood, Malnes, Dickens, Broughton, and Cole reviewed 136 patients from a cohort of 185 in which patients were treated for idiopathic toe walking with either surgery, casting, or no treatment at all. The follow-up ranged from between 2 to 22 years of age, in which the study concluded there was no difference in outcome between patients who were treated with casting to increase ankle dorsiflexion and patients who received no treatment. If the patient is not being severely affected and the parents are not worried, no treatment may be indicated to allow the child to grow out of the toe walking. However, if the parents are worried with the ankle dorsiflexion being severely affected, conservative treatment with casting, stretching, and orthotics to further accommodate the ankle dorsiflexion would be beneficial before considering surgery.